1.
Greetings, everyone. My name is Kert Viele. This is the second ICTR webinar on arm dropping and response adaptive randomization. I'm going to be talking about multiple arm trials. These are useful in a variety of settings, such as factorial designs, dose ranging, and platform trials. These are all settings that allow us to investigate multiple arms within the same setting, either multiple factors, multiple doses, or multiple active treatments. They're efficient. The reason we use multiple arm trials is, in addition to allowing us to investigate multiple questions at once, they also gain efficiencies through the ability to share a control and to share information between arms. The difficulty with multiple arm trials is because there are multiple arms available. If we wanted to have the ability to investigate all of the arms, we need to allocate data to all of the arms. And if we're doing a fixed trial, that can generate a pretty big trial fairly rapidly. So instead of needing to fill 2 arms, if we need to fill 8 or more, this can get to be a big trial. So one question that we would ask here is, well, how can we do this more efficiently? And the general paradigm here is to look at the response, the data as it accumulates, and to change the allocation based on that response. So good arms that are performing well, we increase allocation, and arms that are performing poorly, we either decrease the allocation or we eliminate it. An example that I'm going to carry through for the first part of the talk is looking at the standard of care versus 3 novel therapies. And I'm going to do this in the context of a dichotomous outcome. So everybody is yes or no. We'd prefer they be a yes, a responder. We've got some specific goals here. We'd like to identify the best arm, the best novel arm. We'd like to estimate its treatment effect. So the treatment effect, the relative difference between that arm and the control. We'd like to determine if the best arm is superior to control, standard question for evaluating the power of our trial, for example. And also, while the first 3 goals really are about the scientific integrity of the trial, about the ability of it to answer the scientific question, we'd also, if possible, like to treat patients well within the study. We'd like to have more responders as opposed to fewer, if possible, without conflicting with the first goals. And we're going to do this in a 228-person trial. This was selected to give us reasonable power for this setting. I want to look at performance in 2 scenarios. Ordinarily, we would investigate more, but I'm going to show 2 of them. The first is a nugget scenario. So I've got a control which achieves a 35% rate. I have 2 novel arms which do nothing, arms A and B, and then arm C achieves a 65% rate, a pretty nice improvement. In the mixed scenario, all the arms are effective in the sense that they're better than the control, but to varying degrees, and arm C is, again, the best arm achieving 65%. For a non-adaptive trial, let's assume that we're going to randomize equally to all the novel arms. At the end of the trial, we're going to select the best experimental arm. We're going to do this in a Bayesian perspective, so we're going to compute the posterior probability that that best arm is superior to the control. I'm giving this notation, this PR-PBO, just meaning the probability I'm beating the placebo or the standard of care. And I'm going to declare the trial to be successful if that posterior probability is greater than 99.2%. So I've chosen this 99.2 to maintain a 2.5% type 1 error rate. Because we've got 3 novel arms, we're taking a multiplicity hit. This is similar to a Bonferroni adjustment. If you didn't want to do this from a Bayesian perspective, you could also put in a p-value condition. The p-value needs to be less than 0.008 or so, and you'll get identical kinds of results. So in this particular case, the Bayesian and frequentist designs are very similar. So continuing, this is a graphic. I'm going to randomize this 2 to 1 to 1 to 1, so that's going to give me 40% controls. I've done this because 2 to 1 to 1 to 1 obtains more power than 1-to-1 to 1-to-1. We're going to end up comparing an adaptive design to a non-adaptive design, so I didn't want to rig this so that I didn't get the best non-adaptive design here. So again, the goal for the non-adaptive trial, we're collecting data. This is just a hypothetical set of data that we might see. The controls at 37% or so. Arm C is the best among the active arms at 63, so that would be our selected arm. We would then compare it to control. So this gives us a posterior probability of about 99.8. That's greater than our 99.2. So this is a setting where arm C is successful. Again, if you did this from a p-value perspective, you'd get a p-value of 0.002, and you would also get a successful trial out of this. So how well does this trial work? We can think about this from a variety of questions. How often do we get the best arm? In the nugget, there's one unique best arm, and it's far better than the rest, so it's an easier problem to pick the best arm. The non-adaptive trial gets this 83% of the time. In the mixed scenario, it's lower because there are other good arms, and so you can end up picking the second best arm with some probability. And so the mixed scenario, about 70% of the time, it picks the best one. The power of the trial in the nugget, it's about 83. In the mixed scenario, it's 87. So these are certainly adequate trials, and power's in the 80s. I could ask about what's my estimation error, what's my mean square error of estimating the treatment effect. If at the end of the trial I say, oh, this is the best arm, it has a 20% improvement over control, well, how accurate is that? And so we've computed the mean square error. You see the numbers of 0.0037, 0048. Both of these are, remember, these are squared numbers. So really this is take the square root. You're about 6-7% is kind of a standard deviation here. There's some biases and so forth because we have multiple arms. But again, the plus or minus 12 to 14% on these kind of measures. The number of responders in the trial, in the nugget, remember, there's only one arm that's really good. Most of the people are getting this 35% rate, and then there's the few people who get on that one good arm. On average, out of our 228 subjects, 93 respond, whereas in the mixed scenario, we get an expected number of responders of 107. Okay, so this is our fixed non-adaptive trial. One question to ask is, well, can we do better than this? And so we're going to explore arm dropping and RAR, which stands for Response Adaptive Randomization. In this talk, I'm going to talk about what they are, going to give some examples of how they would behave in a hypothetical trial, talk a little bit about some of there are auxiliary variables that are related, talk about those, and then get back to the operating characteristics, what have they done to power. So both of these methods are based on conducting multiple interim analyses. So every once in a while you look at the data and you make some decisions. At each of those interims, you can compute, you got the full set of data, you can compute anything you want about the data. There are three things that come up often in these settings. We're going to know the p-value comparing each arm to the control. We might make decisions off that. We need to know that we can find the probability that each arm is the best. So we've got arms A, B, and C. What's the probability A is the best of those three? What's the probability B is the best? What's the probability C is the best? So those are going to be three probabilities that sum up to 100%. If an arm is unlikely to be the best, we may want to get rid of it. We're also going to get the probability, this PRPBO, just the probability that each arm is superior to the control. And again, if an arm does badly, we might want to get rid of it. In arm dropping, we look at these quantities and we make permanent decisions to stop allocating to certain arms. And those might be a case if the p-value is too big. Remember, eventually we want a p-value to be small to declare significance. So if it's not sufficiently small, we may drop the arm. If we're talking about the Bayesian quantities, the posterior probability of being greater than the placebo, you'd like that to be big. So if it's too small, we might drop the arm. Or if the probability that an arm is the best is too small, we may drop the arm. So all of these decisions, and certainly it depends on what those thresholds are. Some thresholds are better than others. If we end up dropping an arm, then the trial continues. It enrolls the remaining arms until the next interim, and then we reevaluate. If at any point all the arms have been dropped, all the novel arms, then the trial will end up stopping for futility. So here's an example. This is an interim. Assume this happens at n equal 80, and assume I've put a condition on this so that the p-value has to be, if it's greater than 0.4, we'll end up dropping. I'm not endorsing that particular decision. This is just a for instance on how it works. What we've got is the control is at 28%. I've got 3 arms. Arm A is 43%, Arm B is 62%, Arm C is doing awful at 12.5%. If I compute the p-values, I get 0.081, 0.005, and 0.800. So the only arm that's meeting our condition to drop is Arm C, which makes sense. It's doing quite badly here. So at this point, we would drop Arm C, we'd stop enrolling, and we would continue the trial. So we were enrolling 2 to 1 to 1 to 1. Now we're going to drop that Arm C, and we're going to continue 2 to 1 to 1 to 0, continuing forward. So we're going to continue the trial, but now we're focusing on. So this is n equal 160. And we've got to still have our condition p greater than 0.4. Arms A and B are continuing to outperform the control by a decent amount, 29 versus 36 and 69. And so here we would continue both arms. Both of those p-values are in the right, are smaller than 0.40. One question you might ask here is, even though Arm A is beating the control and its p-value is sufficient to continue, it's certainly far worse than Arm B. The likelihood that that Arm A is going to catch up to Arm B is probably pretty small here, so it might make sense for us to drop Arm A here as well. But that would be changing our rules around. Instead of dropping on the basis of p-values, we'd be dropping on the basis of the probability that an arm is the best. Arm B is far more likely to be the best than Arm A. And so this is just giving you an example of how picking different drivers of these adaptations can change your decisions and potentially change your operating characteristics. If we continued both arms, then we'd go all the way to 228. We'd compute the p-values for both of these. Arm A is a 0.071. Arm B is about 0.0001. And so in this case, Arm B would be successful in that final analysis. Arm C, of course, was dropped a long time ago. When you do arm dropping, you have to make these auxiliary decisions. When do you put the interims? When do you do the first one? How often do you do the interims? What are the thresholds? You could pick a constant threshold over time. You can also change the threshold. Usually when you do arm dropping based on p-values, you change the threshold in something similar to what you'd see for futility with a group sequential. So certainly you have to make these decisions. You have to decide how aggressive you want to be with it. And again, these make a big difference in the kind of operating characteristics. If you do this very, very early and aggressively, you could drop good arms by random chance and the trial might perform badly. If you wait too long, you don't get the benefit of the adaptations. So you should experiment with a number of these or find literature that suggests what's optimal in your scenario in order to make this work well. Switching gears, response adaptive randomization. You can think of this as a softer form of adaptation. Arm dropping is a permanent, irreversible, complete decision. The arm is either completely in the study or completely out. RAR does more subtle adjustments. So good arms have increased allocation, poor arms have decreased allocation. And I've got a bullet point here I'll come back to. The control should always be handled separately in these examples. If you don't handle control right, these things can go very badly very quickly. So control should be handled separately. An example of this, so here is an interim analysis at n equal 80. I'm going to do RAR, and I'm going to do this proportional to the probability of being the maximal arm. So I did arm dropping on the basis of p-values. I'm doing RAR on the basis of the probability of max. And again, you can mix and match these. You could do RAR based on the probability that something's better than the control arm. Here I'm choosing to use this probability of max. This is the same data we saw at n equal 80 for the arm dropping study. But if I compute the probability that each arm is the best as opposed to the p-value, I get the probability arm A is the best is about 14%, probability arm B is the best is about 85%, and the probability arm C is the best. Remember, arm C is doing very badly. It's less than 1%, significantly less than that. If you're doing RAR, one way to do this is to just make the allocation proportional to these numbers. So we could allocate 14% to A, 85, 86% to B, and 0.1% to C. Usually if a number is very, very small, we just truncate it to 0. So usually we would not be allocating 0.1% to C. We'd go C is out, and we'd be allocating arms A and B in that 85-14 proportion. As I said, control you want to handle separately. This has been set up so that we're maintaining a fixed 40% of subjects on control going forward. So if we're talking about we're at 80 subjects and we're going to 160, we're talking about the next 80 subjects, we're going to allocate 32 of them to control. So we're going to keep 40% of them on control. The other 48, until we get to the next interim, we're going to allocate to arms A and B in this 14 to 85 ratio. You can certainly block this and block the controls and do this in a number of ways, but we're going to keep this ratio. One question to ask here is the same kind of question we ask in arm dropping. You can say, is that too aggressive? Is that not aggressive enough? One thing you might ask here is, I've only got 16 subjects. I'm allocating 85 to B and 14% to A. That's not a lot towards A. Is that too aggressive? Did I give up on A too early? The counterargument here is that B is doing a lot better than A. This calculation is really saying arm B is quite likely to be the best. There's data which says that we ought to focus on it. An alternative is maybe we should be more aggressive. Maybe that 14 is not big enough. We should truncate it to 0 as well under the assumption that 14% of subjects doesn't really give arm A time to do anything. So maybe we should be more aggressive. Again, you want to experiment with this in the design phase. How well does a trial work when you're very aggressive or not as aggressive? How well does it work when you adapt early versus adapt later? All of these things you want to explore, and these are the kind of decisions that you're optimizing. So I'm going to continue with that 85-14. Here is the data that we got at 160. So controls continuing along at about 30%. Arm A got a few more subjects and went up to 50. Arm B got a lot more subjects. It's at 62.1. And, of course, Arm C, we truncated that to 0, so it didn't get anybody. The probability each arm is the best is actually pretty constant here. So 16 versus 84-ish. So if we were to continue this, we'd continue to focus our resources on B. We put 40% on control and then allocate in this 16 to 84 ratio for the rest of the subjects. And that would lead us to this N equal 228 final analysis. And so again, we've got about 29% rate on control. Arm A fell back a little bit. Arm B, it also dropped a little bit. This is all just random fluctuation, but it's still at 60%. And in fact, by doing this RAR, we have as many subjects on Arm B as on control. So our relevant comparison, we've got lots of subjects on it. Out of our 228 subjects, there are 183 that are involved in this main comparison of Arm B versus control. The probability that Arm B is beating control is over 99.99%. So Arm B would be successful in this context. This would be a successful trial. There are lots of choices that you can make with RAR to tweak its performance. One question that comes up immediately is, do you want to make adaptations on the basis of the probability an arm is the best, or do you just want to make adaptations on the probability you're beating placebo? You see both of these. If you're just looking for the best arm, you only want the best treatment, then it makes sense to focus on the best. If you're looking among several arms and you want to identify all successful, all effective arms, so you care about the second or third best, then maybe it makes more sense to do probability placebo. Again, it depends on your context and the goals of your trial. I've set this up as I want to find the best arm, so that's why I use probability of max. Whatever that is, call that chosen quantity QX. So Q might be probability of max, Q might be probability of placebo for each arm. I've switched examples a little bit because I want the calculations to come out in an informative way. So letting Q be the probability of max, just suppose that those numbers came out 55, 35, 10. And that's not what they came out in the examples I just showed, but I've switched this around slightly. Some options that you can do here, as I said, we often threshold low values to 0 and renormalize the rest. So suppose I picked that I was going to threshold anything below 15% down to 0. In that case, what I would do is that QC, I would make that instead of 10%, it gets lowered to 0, and then I have to renormalize the rest so they add up to 100% again. So that would get me to the 61, 39, and 0 for my final answers here. The threshold bound is something you should explore multiple thresholds. How well does 5% work, 10%, 15, 20? You can explore all of those and pick the one that gives you the best operating characteristics. Other options that are often done in RAR is to raise things to an exponent in order to make it less or more aggressive. So you can, this exponent, if it were 0.5, for example, what we would do is starting from this, we had 61 and 39, it's where we ended on the last slide. If the exponent was 0.5, we would compute the square root of 0.611, raising it to the 0.5 power, and compute the square root of 0.389, and then we would renormalize those two numbers. We keep the C at 0 because it's already been truncated out. So if you use an exponent of 0.5, you get the numbers in the middle, 55, 56% compared to 44, 45. As that exponent gets lower than 1, what this does is it pushes all those probabilities closer to 50-50. So you can see with the exponent equal to 1, we don't change anything. We've got 6139. With the exponent at 0.5, it's at 55 versus 44, 45. As the exponent pushes to 0, we're going to go to 50-50 with the last one still 0. So the farther you push that exponent down, the less extreme the RAR. So people use this as a mechanism for controlling the aggressiveness. And in fact, you can change this over the course of the trial, making it less aggressive at the beginning and more aggressive at the end as a possibility. one interesting thing to note is when that exponent is equal to 0, since you get this 50-50, you're really getting a temporary arm dropping design. In theory, an arm could come back. In practice, it rarely does. So really what you're seeing here is arm dropping is almost a special case of RAR. If you set the RAR parameters in a certain way, you can get a design that essentially emulates arm dropping. And so that's one of the reasons I'm not going to make a lot of comparisons between arm dropping and RAR, because this is really a function of how you're setting all these auxiliary variables, as opposed to really taking into a different paradigm. Some common properties here. Both of these possibilities, arm dropping and RAR, both of these are superior to non-adaptive randomization, and they're really superior across the board here for multiple arm trials. They're more likely to identify the best arm. They put more subjects on the key comparisons. That results in higher power, results in better estimates. And also, we treat patients in the trial better by eliminating or reducing poor arms and increasing allocation to better arms. Keep in mind, again, both of these must be carefully calibrated. The main thing you can do wrong here is to be too aggressive too early. If you react too strongly to early data, you may be reacting to noise and eliminating arms that you really want to retain till later. At the same time, you don't want to wait so long that you don't get the benefit of the adaptation. So that's one reason you want to experiment with different interim timings, different aggressiveness while you're preparing a design, and pick the one that works best for your particular setting. Returning back to these operating characteristics, this is the calculations in black that I showed before for the fixed non-adaptive randomization. The red is RAR, and again, keep in mind, arm dropping you can think of as a special case. How often do we pick the best arm? Well, we were at 82 or 70%, depending on what the real underlying truth was. In the nugget, this goes up to 96, and the mixed, it goes up to 78, so a decent improvement in both. The power of the trial is improved, 82 to 96, 87 to 94. The mean square error for estimation is significantly improved. We're getting more subjects on key comparisons. So our mean square error is actually cut almost in half here. So you can see these numbers, 0.0037 down to 0.0019, 0048 to 0025. So really a 50% reduction. We're getting a lot less error here. If you take the square roots to get back on the more natural scale, you're talking a 30% improvement in standard deviations, for example. In terms of the number of responders, in the mixed scenario, there's a lot of good arms. This has less of a benefit, 107 to 115. In the nugget, there's only one good arm. The ability to get to it is valuable. We were averaging 93 responders. We're now averaging close to 114. So a significant number of patients have gotten a benefit by getting the better arm here. Again, some notes, can't emphasize this enough. These auxiliary variables are very important, and the allocation to control is very important. So I want to spend a couple slides just showing how important it can be. For control, this is an experiment we did. This is actually the example we talked about originally. The nugget and the mixed you can see at the bottom for the scenario. There's also another scenario I didn't show in the slides here. The y-axis is power on this particular graph. If you look at the rows, so just look at the mixed column here, you can see in the middle in black there's an F40, F50, and F25. Those correspond to fixed trials with either 40%, 50%, or 25% controls. So those are randomizing 2 to 1 to 1 to 1, or 3 to 1 to 1 to 1, or 1 to 1 to 1 to 1. And you can see all of those have power in the 85% range. The F40, which is what I showed, it's the one that has the highest power, which is why it was picked here. There's a really bad trial on here. This is the one at the bottom where it says R adjust control in kind of a bluish color. And you can see the power of this, instead of being around 85, it's really bad. It's about 65%. What that trial is doing is if the control arm appears to be worse, it allows the control allocation to reduce over time. And this generates all kinds of problems. At the end of the day, we need to compare our best arm to control. You have to have controls for that comparison to be accurate. So by adjusting the controls, allowing them to go down, we lose a lot of power here. This is why we made such a big deal about maintaining control allocation at 40%. In contrast, what you see here is there's an R40, R50, and R25 in red. Those are RAR trials. They do adaptive randomization on the active arms, on arms A, B, and C, but they maintain the control allocation. And here they gain power. So you can see really across the board for all three of the columns, maintaining control allocation is with RAR is the highest, then the fixed trials, and then these trials where we adjust the control. So that's why we do not recommend that you adjust the control allocation in these settings. If you've looked at the literature, there's a lot of papers which talk about this R adjust control and indicate other problems of it in terms of biases, and lots of real problems happen with this particular design. So one thing to keep in mind when reading those papers is that's the variant they're talking about, and the RAR that I've emphasized above in the previous slides is really these red trials, which are a really different kind of trial here, different performance. In terms of other variables that you might change, the interim timing, when you start the interims, how aggressively you do it. I don't want to go through what all these graphs are. I just want to emphasize that they can matter. This is a different simulation study and a different example. We just were experimenting, and we varied when you do the interims, when you start, how often you do it. We played around with different thresholds. Anyway, we did about 36 different variants of the RAR design. And the details of this I wasn't trying to emphasize, but I just wanted to emphasize that there is a difference here. If you look at power in the upper left, what you can see is the worst variant has about 73% power, the best variant about 81. And again, this is a different example than the prior slides. In terms of identifying the best arm, that's the middle on top, it goes from 50 to 60% or so. So all of these variables that I talked about, you want to explore a range of these so that you get one of the better variants as opposed to one of the worst variants. So certainly all of these are important. I've talked about multiple arms. Two-arm settings are a really different paradigm here. If you're talking about arm dropping in two arms, it's really just an early stopping design. If you drop the treatment, you're declaring futility. If you drop the control, then you are effectively declaring early success. So arm dropping is really an early futility or a group sequential kind of design. Usually we don't refer to it as arm dropping in two-arm settings. There have been papers that have talked about RAR in two arms, and there are a number of problems. There are some good things, some bad things, but there are a number of problems with RAR in two arms. And really what's going on here is keep in mind this discussion we had a couple slides ago on this R adjust control being badly, if you're doing badly. If you get away from control, you have poor performance. So if you are in this situation where you're in two arms, the only way that you can do RAR, if you increase allocation to treatment, you have to decrease allocation to control. There's no way to maintain it and do anything at all. So two-arm RAR by definition is that R adjusts control, and that's bad. Whereas in multiple arms, we can do RAR on the novel arms and maintain control. So really, 2 arms versus multiple arms, you get a very different set of trade-offs and advantages, disadvantages. All right, final topic. I want to talk about an Ebola example that we did for the West African epidemic. We were doing a trial with multiple therapies for Ebola. Here I'm going to show 5. There were more in our actual example. The example I'm showing has no control. Recall it was a major ethical debate here, but the example here has no control. We're going to talk about a 200-patient trial. One possibility is that I could just allocate 40 patients to each of the 5 arms. I'm also going to consider alternative strategies, the RAR kind of design. My goals here are, again, to identify the best arm, and I also want to treat patients within the trial well, if possible. Now, suppose that, in fact, the true rates are 30, 40, 50, 60, and 70. This is something we wouldn't know going in, but assume this is what the underlying rates are. If I randomize a patient equally, so 1 to 1 to 1 to 1 to 1, then each patient has a 50% chance of survival. They might get the 30, they might get the 70, they might get the 50, might get any of the arms, but overall, if we average that, they end up with a 50% chance of survival. So that's 1/5 times 30, 1/5 times 40, and so on. We knew that this trial was not going to be blinded. Just logistically, it was impossible. And in addition, the results potentially aren't going to be secret. So one natural question to ask is, imagine the ethical aspects of you've got one Ebola clinic who is randomizing patients. And now suppose a new patient comes in. I'm going to call them a VIP. They don't need to be that in any respect, but I'm going to call them a VIP. And now suppose that they go, I don't want to be randomized. I want you to go in and I want you to look at the data and I want you to give me whatever arm looks like it's doing the best right now. So some patients are subject to randomization and some patients are using the full data that they have available at the time. So we know that a randomized patient in a non-adaptive trial has a 50% chance of survival. What about the VIPs? So what do you gain by saying I don't want to be randomized? This graph has their number of lines on it. Let's start with the solid black line at the bottom. So regardless of what patient you are, whether you're patient number 1, 2, 3, 4, patient 100, or finally the 200th last patient in the trial, then you have a 50% chance of survival. So that's why that line is flat. The VIPs, they are the dashed black line. And so how well a VIP does depends on when they get there. So obviously the more data that's been accumulated in the trial, the better the information that they have. So for example, if a VIP arrives after 30 patients have been in the trial, that's on the extreme left of this graph, then they have a 60% chance of surviving. Now, what's going on here is, of course, after 30 patients, they're going to say, give me the best arm to date. The best arm to date is not necessarily the true best arm, but it is more likely to be one of the good ones than it is to be one of the bad ones. So if we just average across how good the arm selection is at n equal 30, you get about a 60% chance of survival. It's certainly better than being randomized. As you move on, patient 100, 150, 200, that continues to go up, and it gets a little under, really about 67% at the end of the trial. So a VIP who comes in at the end has an even better chance of surviving. So you can think of the difference between this solid black line and the dashed black line. That's really the cost of being randomized in this trial. Okay, so now let me consider an RAR design. So I'm going to do 1 to 1 to 1 to 1 to 1 equal randomization for the first 30 patients, and then I'm going to turn on RAR. and I'm going to do it in proportion to the probability of being the max as before. Now what happens is a patient's expected chance of survival is going to increase over time. So what happens if you're the first patient in the trial, you are equally randomized, so you've got a 50% chance of living. If you're the 200th patient, you're still randomized, but you're randomized based on the results of all the patients that came before you, and your chance is going to end up being better. So that is the solid red line. So the solid red line is giving, this is an RAR, this is a randomized patient, but we're getting an RAR design. And somewhat coincidentally here, but importantly, if you look at that solid red line, it's actually really close to what the dashed black line is. So if you are a randomized RAR patient, you really get the same benefit as if you were a VIP on the fixed trial. So that significantly lessens the cost of a patient being randomized. The decision that you have to make, oh, please don't randomize me, I want to get the best thing and have the best chance, the RAR trial is getting you a lot of that benefit. Now, there's still some cost to randomization. The RAR trial actually gets you better information than the fixed trial did. So we could also think about if we have an RAR randomized patient, we could think about a VIP who is being a parasite off of the RAR trial. And so that is the dashed red line here. And so there's still a benefit. You would rather be a VIP, you would rather not be randomized. But the difference between them is very, very small. If you look at the difference in the black, do you want to be randomized to fixed allocation or be a VIP being a parasite off fixed randomization? That difference is 10 to 17%. The difference between being in an RAR trial or being a parasite on an RAR trial is more like 2 to 3%, much, much, much smaller. This has implications in terms of a learning healthcare system. If a healthcare system is doing randomization, trying to improve performance, a reasonable thing to ask is, do I want to be randomized or not? What this is showing is with RAR, you can get a lot of the benefit, allow patients to be randomized and contribute information, and the cost of people agreeing to be randomized, there's a little bit of altruism here, but it's far less than if you were doing a fixed trial. So there are lots of ethical questions involved in this, but this is kind of laying out what's the numerical underpinnings of those ethical questions. So in summary for the whole talk, arm dropping and RAR, they're both based on efficiently moving resources to better performing arms. They both provide significant gains to performance over non-adaptive designs. Both of them are very sensitive to these extra variables. When are the interims? How aggressively are you doing it? And you should certainly explore multiple possibilities. You should see the performance of each and pick the one that's best for your scenario. In multiple arms, these benefits are seen for both external patients. We've got a better chance of identifying the right arm, the better chance of having higher power, the better chance of getting that arm, finding a drug and leading to approval. So that's benefiting external patients by getting good treatments outside the trial, but it also is benefiting internal patients. So we end up with more responses, more survivors within the trial that is doing it. So this concludes our second webinar. Certainly we are available for questions both now and through the website, and I thank you all for attending.